Great. So, Terry, can you hear me okay?
I can. Can you hear me?
Yes. So it looks like we
Okay.
have people starting to log on, and we just started streaming the broadcast on Facebook Live. So thanks so much, everyone, for joining us. I think we're going to go ahead and get started as people start to log on this morning or this evening, depending on where you are in Boston or in India. And it looks like we have some people from Uganda joining too. So I wanted to start by just saying thank you so much to Terry Bresenham, who's joining us today for our next CAMTech webinar series titled What Got You Here Won't Get You There. So Terry Bresenham's role includes regional leadership of GE Healthcare's operations in India and South Asia, Africa, and Southeast Asia, focusing on addressing customer needs across these regions and working with governments, clinicians, private operations, and NGOs to support their complete healthcare system development in the startup phase through established healthcare infrastructure build-out. And today's talk is going to walk through the story of GE's learning in the space of creating affordable healthcare solutions for the underserved population and the evolution of healthcare in this space. So we're doing today's talk on Facebook Live, and we're happy to take any questions at the end of the feel free to comment on the stream and we can take your questions. And then those of you who are joining us on Zoom, there's a chat function on the bottom, so feel free to ask your questions there. And we also have a short video from Vikram today, who is not unfortunately able to join us, but after Terry's talk, we have kind of a short message from him too. So I'll go ahead and turn this over to Terry for the rest of her talk. What got you here won't get you there.
Great. Can you hear me okay?
Yes.
Okay. So thank you very much to the CAMTech team. And, I think it's really exciting that you're doing this. And today, as I said, or as you said, we're been working on ways to think about healthcare delivery processes and how do we use a different approach to solve for challenges in the developing healthcare systems. So I'm going to give you a little bit of that framework of how we look at that. And then I'm going to use one of the examples. We started this about 5 or 6 years ago. We have built from very small, modest beginnings to now what is more than $1 billion business in this. So it's definitely proof that thinking differently and co-creating in these markets is something that we feel very strong about. And it really links to our purpose. We've got a sustainable healthcare solutions business, which at the heart of it is technology and solutions that can bring about better access to care, better quality of care, and certainly lower cost of care. And that's what I'm going to take you through today. And I look forward to leaving some time at the end for some of the questions. And unfortunately, my chief partner in crime, Victor Damodaran, who's our chief technology officer for our business here, unfortunately had to make a unplanned trip to Singapore for very exciting opportunities. But as a result of that, he is going to try to get through immigration in time to join us. But if not, we do have Vikram's voice in this in terms of a video. So without further ado, I'm really excited by what we see as the purpose. There's approximately or estimated 5.8 billion people in the world who lack access to quality care. And we don't think that's fair. And furthermore, we think there's a lot of those reasons relate to the fact that technology is too expensive. Expense or cost obviously is inextricably linked with access. But more than that, there's other things around in the ecosystem that means that even if you can design something of lower cost, it isn't necessarily going to work. And that's some of the points I want to make today is, and why the title of the talk of what got us here won't or didn't result in success in these new markets. So it's been a journey, and it's been a lot of learning, and it's been a lot of co-creation, to be honest, with groups like CAMTech and others in the environments that we're operating, as Nicholas said, across the 54 countries of Africa, South Asia, and the Southeast Asia or ASEAN region. So let me start with what we usually do, and that's think about the hypothesis of what problem are we trying to solve. So as you may know, there's a tremendous infant mortality rate and maternal mortality rate, largely because there's not enough infrastructure and equipment to serve mothers who are child birth processes. And if I were very simple about this, there's two types of problems. The first is there's a lack of equipment. And many of you that have been in primary health centers in the government sector would see this. And if you think about childbirth, three main reasons that children don't survive their first 24 hours. One of those is thermal regulation, especially for low birth weight babies. They just simply can't keep their bodies at the right temperature and expend a lot of calories, which they don't have much of when they're born, and they literally die of this problem. So if we think about that, one way that kangaroo care, for example, putting the baby next to the mother, well, that's obviously, or an adult, that's a great way to try to solve for that. Many of these government centers, though, have things like light bulbs, a 25-watt light bulb. And when you look at that, they're reasonable alternatives in some level, but obviously for many babies, that's not sufficient. It's not consistent. And we know this is why thermal regulation or baby warmers or incubators are so critical in that first 24 hours and several weeks of life if you're premature. The other reason, and that's the picture on the right, is the equipment is not appropriately designed. So maybe they got a donation, or maybe somebody's purchased equipment. And believe it or not, this is an actual picture of a piece of equipment in a birthing center. When I say they're not designed appropriately, that could mean things like it's not reliable, it's too difficult to use, it breaks down frequently, and after a certain period of time, it basically doesn't get used for its intended purpose. So those are the two kinds of things. Either they don't have the equipment, or the equipment they have was not really designed for the setting. I'm not going to go into all the details around the skills and the other things that we know are important in this, but I think for the purposes of today, it's just start with some of the basic principles of this. So as we look at this, when we go into what's a baby warmer really need, and we started with a lot of field research, a lot of observational research, a lot of set of ideas and assumptions. And then after that, we actually started with a prototype. And I think this is one of, obviously a very common process in some level, but I think what we did differently was we actually looked at different aspects and tested them independently versus just build one prototype with all of our ideas in it. So I'll take you through what I mean by that. So for example, the heating element in a warmer, we even looked at simple things like, if it's mounted in different ways, what does that do to the use case? What does it do to how a nurse or a caregiver interacts with the baby, or the access to the baby itself? Does the design have, when I say empathy for a patient, one aspect, for example, would be, does it look robust? Does it look modern? Does it have a sense that it's going to take care of my baby? Because in this case, many times the parents are around in equipment that doesn't look very stable or doesn't look very modern is really a detractor from what a patient, in this case a parent, would feel about using that equipment, and even to some degree actually the caregivers around it. Obviously it has to be clinically effective, and so that's another element of what we obviously test. And then the last piece in the design, for example, of the heater element, is it safe? Meaning, is there any way accidentally someone could get too close to the heating element, or if the heating element is set up against a curtain or something like that. So those are things that we definitely looked at, and here were three. Actually, these are real designs that we tested out, by the way, in the field to get a sense of what's the preference from users. Another element that we looked at is the actual bassinet where the baby is placed. And here again, while it seems like such a simple component, there were actually a lot of problems with the existing designs that we found in the field. And the users told us this, things like it was too difficult to clean, and therefore they were transmitting, infection from one baby to another based on the fact that there was too many crevices or too hard to clean a bassinet. Other cases, it was around how useful is it if I have an emergency situation, how quickly can I get to the infant, or how quickly can I get more equipment in around the infant so that I make sure that I don't have any loss of access to do the things I need to do. And then a third, and this one was by far another very important one, was how robust is the bassinet. In many of these settings, they don't have, plush accommodations, so they get knocked around, they get bumped into, and so many of the things we observed in the field were in fact that the bassinet was just cracked or, had broken and they had to substitute something else. So these are, again, very simple ways to think about this, but valuable in terms of how we built many of our designs to, again, hit the criteria of cost, quality, and access. So then we took a combination of these different ideas, and here's, again, 3 examples of what we actually tested. So different elements of the heater, different elements of the bassinet, different form factors of the base system. And one of the things that we found, by the way, was that you'll see in each of these designs, we ended up adding storage elements. Again, many of the primary care settings across the developing economies don't have, nice sets of shelves, or don't have areas where they can, keep materials clean. And that's why storage elements became an important part of this design process as well. And when we looked at that, we even considered, how do you make sure that you have enough storage? How do you make sure you have a way for the storage to remain clean? And then just aesthetically, does it serve the purpose for patient empathy and usability? And then another component, which again may seem somewhat trivial, but how easy is this to move around in these very small, tight settings? Maybe the floor is not very even. Maybe there's, again, ways that you'd have to pivot. So I just breeze this as another idea of how to look at, in a resource-constrained setting, simple things like the type of wheels, the durability of the wheels, and what the wheels overcome, unevenness, breaks in the floor, dirt on the floor, things that are, again, somewhat common as you look at this. So we love the idea that we take the things that we do, and for, say, the sake of Europe or Japan or Australia or US, but when you get into these settings, you find even small things like the type of wheels, you have to redesign, and you have to think differently about the way you've constructed something. And I think wanted to also look at another simple example. If you look across the world for incubation or baby warmers, it's a very conventional alignment of the heater element up here at the top with the infant in the bassinet, and the caregiver obviously approaching the baby. What was interesting in the setting that we ended up testing this is this orientation, actually, because these are tight spaces, because they may in fact have put more than one infant in a warmer just because of resource constraint. This was not an ideal orientation, although baby warmers for decades have been designed in this configuration, not just by us, but in fact by most all the vendors. So we did a different look. We tried putting the heating element that I show here at the back, off-centered. We tried it at one end, and then we ended up realizing that this was a better design, but then we needed to reach the exterior corners and do that in a uniform manner, which then led back to completely redesigning the heating element, because this design is much easier, whereas this is off-centered and smaller, meant we had to go for a different type of technology in order to achieve the uniformity of a bassinet warmer. And you can see here the difference from the caregiver in a tight space. She may not have enough, or he may not have enough space to reach in, whereas this off-centered back of the bassinet design actually led to a much more accessible, and as I said, many times we find in resource-constrained environments, they may put more than one infant in a warmer, which we wouldn't see in a Western setting. So if we go to that is just a simple example. Now I want to talk a little bit more about why, as a company, we're so excited by how to use technology to solve very fundamental problems, but using technology in very different ways than what we would have in just a traditional, developed or established healthcare system. So on the upper left here, I would use the term kind of the current market. You design a product, you try to differentiate that for different markets and against different types of competitive dynamics. And when we did that, obviously we had to address the cost structures, and we had to also work with users to figure out different adoption techniques, because we often go into settings where we don't have conventionally trained healthcare providers. And by the way, I think it's not necessary. If you have the right design, you can have alternative users using this technology. You can also have different locations. So that's a big piece of it. But I would use this as one of the ways that we've iterate, build something, measure its effectivity, and then try again. So I think as you think about your own innovation processes, I think this is really exciting place, but one that I would encourage you to discard a lot of your existing or conventional notions to come up with new ideas, as I just spoke about on something as simple as a baby warmer. The other piece, which we have also spent a lot of time on, is how do you get into the marketplace and get people to understand, while this looks different, technical specs may be unconventional, but how do you make sure it actually makes for a very effective clinical solution at a very different cost structure. So that's another area that we look at, designing specific go-to-market strategies, different types of partners in the market in order to get this technology in the right places, and how do we work with governments and key opinion leaders to make sure that they understand why this new design or new approach is going to be effective, and in fact, in many cases, more effective because of its different design. On the right-hand side is another set of areas that we've, as a result of doing this, that we've actually expanded our business model around, and that's how do we think about technology as one component. It actually, to look more holistically, is all the other things that go on around a patient and a patient in its given care delivery process. So whether that's primary care, whether that's maternal and infant care, whether that's cancer care, surgical care, et cetera. So we've actually walked through the patient's journey along with all the other people that are involved in the delivery of the healthcare processes to make sure we look for the points of friction. And sometimes we take portions of this and fold it back into the product or the information digital technologies, or in some cases we find other partners in the market to come together because our component plus theirs is actually a more effective way. Or it may be to provide additional types of capabilities around technology. For example, how do we do skills development? Prior to us being in this, we would train people college, and we can design processes and they can go into the healthcare system and actually use this technology and make sure that the patient's outcomes are not compromised at all. So just a simple example. In GE's world, as we think about the emerging markets, as I said, we think about the different tiers of care, whether that's at the very front end of the system of healthcare in the primary care settings, rural settings, whether it's in the secondary systems or whether it's in the tertiary or super specialty systems. Most of the markets that we serve have limited amount of tertiary care, and as a result of that, it's the other side of the problem is it's over it's under capacity or over capacity from the serving the patient. So that system is really difficult. So we look for solutions that actually will provide better care at the primary and secondary level. And as we go out in the primary care level, there's not a lot of patient outcomes in the functionality of those systems. And that's what leads back to this whole innovation process, and surround that innovation process with things, as I mentioned, of like skills development and care pathway and decision support, so that we can help governments or help the public sector develop ways to better serve their populations at a lower cost, but with a assured a pathway to get to better clinical or patient outcomes. So what does this mean to us now that we've been at this for about 5 years? From the market itself and the emerging markets, it's estimated that there's an $8 to $10 billion product or medical technologies market for these underserved areas in the world. So when we say there's 5.8 billion people that lack access to quality care, that could translate into, for the technology that it would take, a roughly an $8 to $10 billion market opportunity. So that's awfully big and clearly a exciting place for any company or startup company to pursue. It is a mix of private and public, and it depends on which countries you're in on what the proportionality of that is. But one of the other things that's obviously important is if you're going to design a new type of approach and those specifications may look different, then we have to take a look at how do we bring about better opportunities for governments and the tendering process to understand those. It is very highly fragmented. There's many domestic companies in these markets as well as the multinationals. So that's one of the challenges that you face. And then there's also, as I said, that we had to work with distribution. How do we activate this in the market? How do you get people to know that it exists and why it's a different and maybe a better approach? So a lot of activity that we do is, again, as you can see, beyond just the development of a technological solution, we've had to change a lot of the other aspects of our business in order for us to compete and provide a broader reach of products and services for these markets. The other thing that we've been doing, and I think it led to a little bit more of business model innovation, is around how do we help create more market. Plenty of places around the world, especially the rural segments, there's just simply not a thought process of how to bring about a holistic set of solutions. And why I think this is so exciting is the more that we've gotten into this, we've expanded our thought processes, we've added more capabilities in our own group, but we've also partnered with a lot of different organizations, some of those being aid agencies, some of those being the ministries of health themselves, and some of them are in the education space. But this is an area that we don't see as much competition because it's hard. First off, you have to take a lot more risks, which not as many companies want to do. And I think it's a process of iterating. And we've made plenty of mistakes. I could probably spend a whole half hour speaking about some of the mistakes we've made in trying to do this. But I think at this point, we've got a much better approach. We understand how to do this, again, cost effectively. And it allows us to be more differentiated with the products that we have. One last thing I'll say is that inside of healthcare, whether you're in the developing markets or whether you're in the developed markets, the idea of how to use data and data analytics to augment everything that is done in healthcare is certainly, again, a very exciting place, and one that is a it's very nascent in some level, but I think in the next 4 to 5 years, this will be one of the more fundamental kind of tectonic shifts in the way healthcare gets conceived and the way healthcare gets done. So if I kind of wanted to summarize beyond the barriers of regulations and how do you do post-market support of a product, I'll just go through some of the other things that are important. We talked a lot about technology. I've mentioned the idea that partnerships matter a lot. How do you go to market and your distribution channels? How do you prove your outcomes? And I think this is something that we're really keen to bring in, groups like CAMTech and others. And how do we look at the effectivity of what the solution is, bring about different components so that when someone's trying to deliver healthcare, it is a very complex workflow. And if you haven't given enough thought to this, this is one main reason I would say many times a good technology never makes it in a scaled sense, because it needs other pieces around it that weren't thought through. On the other side, I would say they're more the softer pieces, but how do you get advocacy for what you're doing? How do others speak on your behalf of your activities? How do you engage with different financing capabilities? Many projects around the world, they're not for lack of want or understanding. They're simply not enough money. And I think that's a key place that we're trying to work with funding agencies. And, if I look at, for example, a Gates Foundation or USAID or UK Aid, they've put, an estimated $8 billion a year into Africa, for example, for healthcare products or healthcare services. But not a lot of that leads to very sustainable activity. And one of the reasons we even named our business the Sustainable Healthcare Solutions is because we don't see enough thought process on how do you design and how do you construct and really how you operationalize a healthcare system. And this is one area that I feel is really important to sustaining something and having it sustained financially. And then, of course, there's engagement by the medical community, the regulatory communities. How do you build things that will last and deliver on the promise that you've made? And then I use the word empowerment, but I think part of this is we look because there's not enough expertise. And some of the things that we've done actually empower patients or empower patients' families to participate in the care delivery process. And I think that's a really exciting area as well, as we try to overcome all these barriers that are sitting in the system to bring about better healthcare. So before we close, or before we get to the video that Vikram wanted that I wanted Vikram to show, I'll just leave you with a kind of a list of questions maybe that we use as we go through our process. The first one might seem very straightforward or very obvious in some fashion. What problem are we really trying to solve and for whom? And when I say that, it's because we jumped off into solutions. We don't think through, well, that was one approach, but what underlying problem are we really trying to solve for? And if I use the simple example of a baby warmer as one example, we were trying to solve for thermal regulation, but actually what we were also trying to solve for is how does this work in a very constrained space? How does this work for more than one baby being put into the bassinet? How does this work for people who aren't going to have all the resources to replace, for example, if the heating element goes out? We ended up therefore designing something that could solve for more than just this straight up clinical problem inside of this. And then who are we solving it for? Is it for the patient? Is it for the caregiver? Is it for the parent? Is it for an allied portion of the service that is around it? I think these are good questions to ask yourself before you jump into more just the clinical design. We often look at who the user is. And again, we have a lot of conventional users, but we also have unconventional users. And have we designed for the unconventional user as equal as we have for the conventional user? In healthcare, and maybe in some ways in any endeavor, you have to ask how you will monetize this, how much can they bear, will they perceive value in this, I didn't go into much detail in this presentation, but I would say this one also is a really important set of hypotheses to test out. And then, you know, beyond the thing that we're doing, we also look left and right at the steps. So what comes before and what goes after whatever component of technology that we're involved in this care delivery process. Because again, sometimes the friction comes before, or sometimes the friction in the system or failure in the system is just after. And so we think about, is there a way for us to, you know, avoid that or improve upon that? Because again, that'll lead to better patient outcome. And then the last one I would say, or second to last one, is what does the overall ecosystem look like? You know, when a patient or a person comes for healthcare, it's not in a vacuum. There's a tremendous amount of other things happening around them. And when we look at that, it has helped us to address other issues or bring about connections within the system. And I'll give you one example in the case of prenatal scanning in a project that we did in Nigeria. One of the fundamental problems was women who were being scanned who said we could tell them they had a high-risk pregnancy, that it's advisable to have a delivery in a hospital, don't have a delivery at home or in their village. Well, one of the things we didn't understand was that it was actually considered weak. You'd be a weak woman if you didn't have your baby at home with the local midwife. So we had to overcome that in the system, and we did that actually by working with the Ministry of Health, but we also did that by working with the village leaders to explain why it's nothing to do with the women's, you know, constitution, if you will, of being strong or weak. It's actually because sometimes babies are in a breech position, which, you know, you're really increasing your risk for a mother to die during childbirth if you don't have a birth in the hospital. So those are things we've looked at as well. And changing behaviors is a really important piece of the tipping point for adoption of technologies. So that's the overall view of how we've gone about this. I think it's been really exciting. I have to say, you know, more than the financial results, what's most rewarding to us is when you finally get that set of technology changes, it actually delivers on that promise of better healthcare at a more affordable cost. And with that means we can bring access to care to more people. So with that, I'll ask Nicholas if you can play Vikram's video. That would help maybe illustrate some of these points further.
Sure, I'm gonna go ahead and pull this up here.
Hey, this is Vikram here, coming to you with the Lullaby Warmer Prime. You must have heard Terry talk about this product in the preceding few slides that she showed you, but I'm just going to walk you through how we've broken down the barriers to adoption for infant warming in primary care settings. So the first thing that you'll notice about the Lullaby Warmer Prime is the fact that the bassinet is oriented in an east-west configuration. In almost all warmers globally, you'll actually find that the bassinet is oriented with its short edge facing east, so the longer edge on the sides. It's called north-south orientation. In this case, primarily because you want to overcome the barrier of the nurse having the fear of dropping the baby when she turns the baby around. That are meant for primary care, they all come with a ratchet mechanism to move the bassinet up and down depending on the need to tilt the bassinet and the bed association. In this case, what we've done is we've provided a very simple mechanism of a mechanical wedge, such as this one. So all you need to do is, if the baby is suffering from nausea and if it needs to be tilted up with its head up, all you need to do is slide this mechanical wedge under the bed and you're all set to go. So that again makes ease of use extremely acceptable for a nurse who is untrained or semi-skilled. and at the same time does not reduce clinical efficacy in any way. A very, very important clinical reason to actually build the foam of or the mattress in a certain way is to prevent infection and to drive sanitation controls. In most primary care settings, the way they drive infection control is by wiping the bed off with a swab of cotton dipped in spirit. In this case, what we've done in order to make that process effective is we've actually made this mattress completely stitch proof. So there is no stitching on the mattress in any way. It's completely vacuum sealed and formed over form. So that way, when I dab a piece of cotton and spirit and when I wipe the mattress clean, I'm able to completely rid it of all forms of blood and all forms of body fluids that are left on the mattress. So making it not only easy to clean, but also sustainable in the form of usage, thereby preventing infection. There's another interesting aspect to this warmer. This particular piece of wire, which actually extends from the feedback control unit to the thermocouple, the probe that measures temperature on the baby's skin, is actually not made of the usual plastic wire that you see even on some of our high-end warming systems. What you actually see is a wire made of Kevlar. And the reason why Kevlar is so important is because 3 months after usage, when they've run out of the special consumable that's meant to wipe down this piece of wire, they would again take another dab of spirit on a piece of cotton and wipe it clean. But if it's normal plastic, the plastic gives way, it loses connectivity, and there's no feedback control anymore. In the case of Kevlar, you actually find that it's resistant to all forms of wear and tear, and therefore drives sustainable usage of the product over a period of time. The last example that I want to leave you with, maybe two more. One is the heater head design itself. As you can see, it's recessed on one side of the warmer. What that gives you is a completely open space for the nurse to work with. The biggest barrier that we were overcoming there was the fear of either burning your elbow or burning the baby as you were moving the baby into the bathroom. Now with that on one side, you again give total comfort for the nurse to put the baby in safely, but more importantly, it does not compromise on clinical efficacy because even though it's recessed on one side, you have uniform distribution of heat on all 4 corners of the bassinet, thereby driving effective thermoregulation for the baby. The last point is when you take a look at these casters here, these casters cost us about $50 a piece. They are much more heavy duty, much more highly reliable compared to some of our high-end warmers. And there's a reason for that. One of the first things that we learned when we actually compromised on cost and made these caster wheels small was when we took them into a primary care clinic. Most of the flooring in a primary care clinic is made out of red oxide. So you see large cracks on the floor. When you try to wheel these things over the cracks, in many cases you find that the product almost tops over. So in order to prevent that, this was one area which, like the Kevlar cable, actually adds cost to the system, but at the same time adds immense value to the user in terms of breaking down barriers to adoption. So that's a summary of why, from a design standpoint, the Lullaby Warmer Prime is probably the most differentiated warmer in the market. But at the same time, as you will see in the next few slides that Terry is going to walk you through, it's not just the product innovation that's important. It's a whole lot of external barriers that play a key role in driving sustainable adoption of products such as these, especially in a non-consumption market space. So I hope you find the rest of the talk interesting. Both Terry and I are accessible both on the internet and CAMTech. Been an outstanding partner in healthcare.
So much, Terry.
Okay, yeah. So sorry for the video just not coming through exactly as well, but maybe it hopefully gave a little bit more tangible examples to, or real life examples to what we've done.
Yeah, sorry about that. I hope everybody else was able to hear it okay. But thank you so much again. I think it was so interesting to hear about this, the ideas of the softer side of design, like considering advocacy and engagement and empowerment I really liked that example that you used about the Gates Foundation and UK-Aid and USAID, and thinking about how do we engage kind of vulnerable populations in design thinking. And I think that's really fascinating. So I know we have a lot of other people signed on Facebook and Zoom. So I think we'd be happy to take any questions that you have for Terry. So for those of you who are watching on Facebook Live, feel free to comment on our page. And then anybody who's joining on Zoom, feel free to write your questions in the chat box, and we can start answering them.
And Nicholas, I see a few questions on the Q&A here. Should we go ahead and answer those?
Sure, go ahead.
Okay, so one question is, how cost effective are the durable product lines for emerging markets, and would you consider inducing these lines to the US and other high income markets? You know, it's a great question. Initially, of course, we didn't design for this purpose, but I think overall, I would say globally, there's a need to reduce the cost of healthcare, and that is one of the reasons we are seeing adoption of certain of these technologies in other parts of the world, and including the US. So I don't think these are necessarily, if they're designed well, I think these are going to be effective in any market. And I think if I look at Europe or US, for example, there's still a tremendous amount of rural population. And that's an area that we see these types of products being effective, is actually in the outreach, if you will, of even a developed market. But our target goal was whatever we designed would have to be 40 to 50% less expensive than what the conventional technologies were. Next question was, I have a question for how does the 8 to 10 billion low resource hospital market globally compare to all the other opportunities GE is pursuing? And what are the challenges in keeping focus and resources on the issues of appropriate medical device development and implementation within GE as compared to all the other ways GE could focus its efforts? Again, it's a great question. The overall marketplace for medical technologies and I'll kind of scope that to the things that we do, is in the trillions of dollars. So while the 8 to 10 is big, it's actually a pretty small portion of the overall spend in the healthcare system globally. But what I think is important to us is that 8 to 10 billion is actually largely an incremental business to us, because it wasn't a place we focused. The second thing I'd say about that is why that market's so attractive to us is it is a growing market. It will probably continue to grow for the next 5 to 10 years at a kind of double-digit rate. And I think, as I said earlier, it actually introduces us to new users. And I think that's from a long-term business model, that's always a good thing, is to keep adding to the base of customers that you do business with. And then the other reason we like it, of course, is that there's a purpose behind it. I think it's if we can do something using a lot of inherent, what I didn't mention is a lot of times the software side of this equation, we've got a lot of wealth of IP in terms of algorithms, of decision support. We can migrate those down onto lower cost hardware platforms that can bring the access to better care, obviously, to more people. And that we feel is also important. On the other question of how do you keep the focus within a large company, it's why we formed this new business in 2016 to be exclusively focused on the developing economies and the needs and the relevance of what we needed to do for those. That's why we set up a standalone business, which is incorporating these 70 countries. And that's the way we've been able to manage to keep focus on this. The other way is, when you look at investments of capital, you're always judging, it's the better returns for that. And I'm happy to report that the returns for these investments have actually been really good. And so that's another reason we have continued to provide resources around this. Another question is, I'm curious, what are your processes at the Sustainable Healthcare Solutions business for choosing and then engaging busy users during design processes, including the unconventional users? I don't think we have a perfect answer here. When we are in the busy settings, and most all of these are very, very busy, patients lined in the hallways, very few staff to support the patients, let alone interesting questions from us. We've done two things. I think one is we've tried to create innovations, opportunities where they can be out of their busy centers, but still be in setups where we're emulating. So these co-creation setups where we can bring the users along with engineers and technologists and create prototypes in a setting that's emulating the busy users center is one idea or one way we've been doing that. The other is, I think when we try to create a new set of solutions, we do pick carefully who's going to collaborate with us. And one of the criteria is, will they have the time to do this with us? If not, we may still come back and do some kind of validation or testing with them, but we won't use them for the primary component of design. So I think that's one area that always will be a challenge. But on the other hand, to do observational research, that's exactly where you want to be, because you can actually see where they have to do multiple things at the same time, and your design is dependent upon making sure you make your system as robust as possible. Another question was, I'm curious, what words of encouragement would you have for someone who is thinking, I'm not an innovator, that's not me, particularly girls and women who feel intimidated to enter the medtech innovation space? I think in the healthcare world, there's many different facets. And what I would say is, in terms of the way healthcare gets delivered, 75% at least is being delivered by women. And many of those women are so vital to the healthcare process. I'm a little bit biased here, but I think if more women were involved in the innovation for medical technologies and more women were involved in the design of healthcare delivery, we'd have a better healthcare system. So even though someone may think they're not an innovator, it doesn't mean you have to be a technology innovator. You can be a care delivery innovator. You can be a systems design of an operations innovator. But I would encourage more girls to get interested in healthcare, and obviously more women to be in the healthcare space, because I think it'll lead to a better system design. So those are the questions I saw online. Here's one more. For a biomedical engineering graduate student who's interested in medical device development and infrastructure poor settings, what type of opportunities are suitable in this area at GE Healthcare? I would say there's plenty of ways, and depending on where you're located. We've talked today about technology design, and a biomedical engineer is clearly well positioned for that. But I'd also say, we look at the healthcare delivery systems across the world. They don't have enough biomedical engineers to support the ongoing quality control, maintenance, when we look at radiation safety. So I wouldn't discount the fact that being part of a hospital healthcare delivery system and being able to set up systems to ensure that healthcare technologies are being used properly, or being calibrated properly, or being maintained properly is an area that there's an unmet need everywhere we go. So that could be an example. And then clearly, I think, as I said, in terms of data and data analytics, that's another place for which biomedical engineers or data scientists are in short supply as well. One more question. Local government budgets as well as foreign government aid is often used to buy newborn equipment. How do you ensure these entities are picking the best equipment within your GE portfolio for their context? For example, a lullaby warmer versus a lullaby warmer prime. How do you ensure they place this equipment at hospitals who have trained workers who can competently use this equipment? What we do multiple things here. For example, one, we work with the World Health Organization. We help them understand what technologies are coming and why technologies are appropriate for different settings. You know, when you look at technology today, there are many, many choices. So we try to look at ways we can explain what economic value there is, what clinical value there is, and where there's technologies that are different than what has been in the past, why those have advantages. And like in the video that Vikram pointed out, when you look at the thermistor, which is to measure the skin temperature, which is the feedback loop to make sure that the thermal regulation is being done within, you know, half a degree accuracy, I can tell you how many times we go out and that thermistor, that cable has been broken. So when we explain to the World Health Organization, because they put out every year a compendium of recommendations for governments around the world, we explain to them, you want to be able to put that in because that's something that it leads to better patient care. If that thermistor is broken, the thermal regulation for that baby is substandard, and as a result of that, they may not survive. So something as simple as that. And then I think from the training standpoint, we've been extremely active in trying to train people to ensure that they are using equipment properly, they know how to maintain the equipment, and when they have a problem, we have an access point for them to reach out to us so that we can address that. And there's certainly one thing we didn't talk about, a lot of staff turnover in these settings often. And so how do we make sure we can give solutions for the low cost ongoing training that's needed in these settings? Another question, can you talk about how people consider engaging with your 5.8 accelerator? So I'll explain a little bit. Our 5.8 accelerator, which is for the 5.8 billion people in the world that lack access to quality care, was designed to work with startup companies that have reached a certain stage in their evolution. We're kind of the sweet spot that we're looking at is groups that have demonstrated they can, generate some revenue from the product that they have or the design of their system. They're probably in the post-Series A kind of model, so they're looking for their expansion. And one of the things that's always a problem for small startup companies is, how do I scale? How do I scale globally? How do I get into the marketplace beyond the few places that I've started with? So 5.8 Accelerator at GE is actually to invite companies at that stage for us to work with them and see if, because of our massive investment in distribution across the world, can we use our distribution channels to help these companies scale in a cost-effective manner. And we're also doing this because I strongly believe that when you look at the solutions needed in healthcare, you need a whole set of things. Not one company is going to have all that. So if we can have partners in this, we're very open to that. And 5.8 is designed to do that. And along the way, it's a chance to also share some of the things that we've learned, whether it's in supply chain, manufacturing, post-market surveillance and support, regulatory, IP protection, those kind of things are also, we consider that as part of the ecosystem of our 5.8 of our accelerator. Another question, what types of financing support or structures does GE provide to make these products more accessible to healthcare facilities? So we do two things. One is we have our own captive in-house financing capability. It's from our GE Capital business. We can go and support financing of products. The other is we work with local banks in the markets that we serve, helping them to understand what healthcare is. In some cases, sharing the risk with them, especially when it's a new healthcare system. And then the third thing that we do is work with the aid agencies. And we can put together capital structures that will help governments expand healthcare systems in a much broader way. And again, we will do things where we help operationalize those, we'll help in sharing the risk, in providing proven outcomes. But it's really, as I said before, it's one of the biggest impact or biggest barriers to expansion of healthcare is just finding the money to do it and finding the money to support the operations on an ongoing basis. Another question, how long did it take from design to prototype to finally bring the product to market? Well, that does vary based on the complexity or the differences in the way we want to look. But if I use the example I shared with you today, the baby warmer, it took us approximately 20 months from conception to the product that we ended up launching. But in the process of that, of course, was a lot of iteration and some of the design elements, particularly like the invention of a new heating element was one of the bigger long lead items in that. But some of the programs we've done are relatively short. Some of them have been as long as 3 years. But again, it just depends a bit about how complex is the design or how different is the design and technological challenges. Another question, what regulatory approvals are required for such kind of products, US FDA or the EMA or others? I think this is a choice you can make because we've intended to serve the developing markets. We of course follow the needs and regulations of each of those markets. And I can give you, in the 70 countries that we've targeted, every quarter there's approximately 100 regulatory changes. Some are very small, but some can be substantial. So it's not just, it's not a simple thing to keep doing, but I think the good news is there's a lot of overlap. So if you do it for one, you have a chance to satisfy others. We have pursued the US FDA clearance for most all of these products, but I do that because it's a global nature of our business and we want to serve, all the markets in the world. And we do things like CE marking because that's another important regulatory approval. But you can do, what I'll say is that you can target certain markets, you can develop your technologies there, you can launch them there with some minimal amount of regulatory approvals. But what I would say is more important is that you should always follow, what's patient ethics, what's patient safety mean to you. And I think, in addition, you can follow the regulatory pieces, but we often take more precautions than what is even asked for, if you will, from a regulatory environment. Another question, I'm curious, how did you become involved in the sustainable healthcare solutions at GE? I'm a biomedical engineer by training. I joined GE Healthcare straight out of graduate school, and I've been involved in technology. I think technology is still really cool. It's my own passion, I guess. And I came to India in late 2011 to help us with our overall business in India. And out of that began the process of thinking about the things that we were doing, let me say. Well, while they could serve certain aspects or certain portions of the market, they certainly couldn't serve all the needs in the market because we were just too expensive. So that was the impetus to begin this process. And then as we began to chip away at the cost of technology and coming up with these new ideas and new solutions, that's what led to thinking about the whole business model of healthcare and how do we do other things that can help healthcare systems, whether those are governments or whether those are private sector healthcare systems. How do we give them more of the tools and the capabilities and the solutions that they actually need? So that's why in 2016 we really wanted to focus in a very scaled manner around this and form the sustainable healthcare solutions business. Another question, which markets in GE's sustainable healthcare solutions business is hoping to focus going forward? Which countries, what levels of hospitals, tertiary, secondary, primary? So on one hand, we're very keen on, as I said, task shifting and site shifting. In the developing markets, the primary and referral care network or system is really insufficient. And if you don't try to help build better primary care systems, it will only have a limited effect because only tertiary is not enough to change healthcare outcomes for countries around the world. So we are working a lot on primary care. We're working on not only technologies, but also training systems, digital data analytics systems, because I think that's a way that we can provide better front-end triaging of patients. And also, I would say even better preventive care, which is something that I know many of you on this call will have understood. That being said, we're also working, I would say, on the other extreme, which is acute care, things like safe surgery, things like advanced cancer care, so that, whether you're a citizen in, Germany, or whether you're a citizen in the US, or whether you're a citizen in Namibia, you should still get access to quality international standards of care when you have a severe problem. So that's the other area that we're working on. Last question. How many governments has GE Capital partnered with to bolster their healthcare systems, and in what regions of the world? We operate in about 160 countries as a company. When I look at some of the bigger healthcare projects we've done, there's some in almost every continent, but I'll give you a couple examples of things that are, I think, novel. We launched in Kenya. We took all the government district hospitals, which was about 100, including the ones in their conflict areas. We laid out a plan that said if you had better diagnostics, and in the healthcare decision process, if you can more pinpoint what's wrong, you're more accurately going to treat the person and use less money to treat them typically. So we said if we took all 98 of your hospitals, we could put together a better diagnostics capability, which was equipment plus people plus digital connections, a network. And then we could find and help you find the structure, the capital structures to put that around. We could build the buildings in a layout that would make sense. And that we could then be on the hook to support this with you to serve the patient's outcome for the next 7 years. That's a project that we did. It was a huge step forward for us to take that much risk. It allowed the government of Kenya to provide instantaneously across their country, in all corners of their country, a better diagnostics capability. And it's been a huge success. I mean, success in the sense that they're serving now on a monthly basis almost 150,000 more patients every month. They're doing that with better quality. And the outcomes of patients surviving things like road accidents, for example, is or pregnancies or trauma has been extremely important. And the data is, they've actually got the data now, they're going to publish this, but I think that's another example of they pay a monthly fee. So they were allowed to modernize their entire country's healthcare system, but on a very predictable cost basis, and with 7 years of support behind it for both training and maintenance of the system. I think they're going to have 7 years of really good healthcare across Kenya. So as one example. So I think I'll pause there. I think we're up on our time here, so.
Yeah, thank you so much, Terry, and for everybody who joined for all these great questions. And thanks to Vikram too for sending that really great example that kind of helped us see what you were talking about throughout the presentation. And thanks again, everyone, for joining us. And please feel free to reach out to CAMTech if you have any questions. And thanks to Terry again. We're so excited to keep talking and continuing this conversation and learning from each other.
Great. Well, and anybody coming to Bangalore, India, let me know. We'll be more than happy to host you.
Great. Thanks so much, and enjoy the rest of your day.
Okay. Thanks. Thanks, everyone.